All right. Well, welcome. I'm filling in for Dr. Bird, who's out of town today, learning great things. I'm Dr. Eric Kuhns. So thank you for joining us. I can't compete with Dr. Bird's bow ties, but I did put on a tie for you guys today. And we've got lots of great stuff to talk about, lots of news in terms of early therapy, boosters, and that sort of stuff. So first, we'll go through some of the numbers. Matt, I think you've got the graphic here we can bring up on the numbers. So with Whiteside County COVID, you can see the red line. We're on a downward trend little by little. 101 cases this last week, 122 the previous week. Looking at the last month, there's 223 cases the last month, 298 the month before. So though I think we've peaked sometime in that time, hopefully it keeps coming down. It doesn't seem to be going down really quickly, as you can see on the results on the right. We did have one pretty robust day in terms of new cases, reaching almost 40. But for the most part, we seem to be trending down. So that's encouraging. Hospital numbers are coming down. We got into the 20s for a while, which got a little stressful for sure in terms of just keeping up with all of that. But I think we're down into the low teens or less recently. You can see in Whiteside, our positivity rate's 3%, a little bit higher than the state of Illinois, but getting lower. Case count was 12 as of yesterday, and fortunately, no new fatalities. We did have some this week, but not today. So that's good. All right, so let's move on. I'm going to talk briefly. There's been a lot of interest in early therapy, and there have been some new things here and also coming down the road with early therapy. I do want to say, I got to quote Ben Franklin every once in a while, an ounce of prevention is still better than a pound of treatment, so to speak. It is almost always better to treat it. So most of these things, when we're talking about percentages, these are people who've already got it that then we're trying to kind of salvage. One of the benefits of prevention is at least a good amount of the time it doesn't happen. And one of the kind of unfortunate things, I think, in cases of terms is a breakthrough case sounds like a failure. Obviously, we'd like people to not get infected at all. But if you get infected with a minor case that would have otherwise been a very serious case, that's what most vaccines do well, is they prevent serious cases the best. That's also a win. It's especially true for COVID because there's a long time between when you get infected and when you get really sick. So if you have any immune memory from previous infection or from immunization, or better yet, both, during that time, if your antibody levels have come down some, you may not be able to fight it off right at your nose, so to speak, but you can still fight it off before it gets bad and you end up in the hospital at day 7 or 10. The people that I see getting in real trouble are the people who generally have no immunity of any sort, and they feel confident because they've come so long and they've done so well for so long that I must be good, but they never really had COVID, or they just thought they did. And they come down with it and they go through the full scope of the disease. And, I had 3 people of my own this week, over the last week, that I was taking care of that way. And that was the case for all of them. For me personally, I have not yet had to admit a patient who was fully vaccinated to the hospital. I've had people with breakthrough cases, but nobody who ended up in the hospital. And that's been pretty typical. I have 5 partners. We care for about 10,000 people in total. And all of us have had, at the most 1 to 2 people who ended up in the hospital who were vaccinated, and many of us none. And all of us and all of our 10,000 patients, and we're pretty ambitious about getting people vaccinated, all of them have not had to admit a single person to the hospital for a vaccine side effect. We've all seen vaccine side effects. None of them have been major or long-term in our experience. That's definitely not typical. And 0 of them have required inpatient care in the hospital. So that's a pretty good run. I mean, we've been at this for a good long time. So let's move on and talk a little bit about early treatment itself. What happens if, whether you get vaccinated or not, you do get an exposure? Well, a lot of that, in either case, depends on the health of your immune system. And so things like adequate sleep, exercise, if you're ever going to get started with that, now is the time. It's especially important now. Vaccination is super important, but the vaccine only leverages your immune system. If your immune system is not in good shape, then it can't really do the work. The vaccine's long gone by then. It's only that your immune system has been alerted to what this looks like, so it can get on it much more quickly. Conversely, a healthy immune system can definitely help, but it's certainly not a guarantee that without an idea of what this thing looks like, that it can get on it, especially if you get a really big high viral load. If you're exposed to a high viral load, even with a healthy immune system, you're going to end up in trouble, and you don't know who that person may be. If you've had some immunity from the past, however that came from, even with a very high viral load, you're likely to get pretty sick, but not end up in the hospital, because you can spin up an immune response from the memory cells quick enough to keep it from being an issue. But let's say we did get that high viral load exposure, and now we're sick, or we've tested positive. What do we do in that situation? Well, first of all, please reach out to your doctor, because there's a lot more that we can do now. Things like the monoclonal antibodies that are, they're in the news a lot. They are very helpful. If you've already gotten to the point that you're sick, a lot of water has passed under the bridge as far as your contagion to other people and some of the inflammatory stuff that happens. But at that point, we really want to keep you from at least ending up in the hospital. And the monoclonal antibodies, they do a good job of that. They decrease the risk of about 70%. Vaccines are well over 90%, but if that ship has sailed already, you're sick, or if you have a bad breakthrough case, we want to do everything we can at that point. And the monoclonal antibodies, they reduce that risk by about 70%, but you have to get them within the first 10 days, and earlier is far better. So please let your doctor know. We have expedited ways to try and make that happen. It's an infusion that it can be given in the hospital. Again, we've got that process streamlined and down pretty well, but because it's an experimental use thing, and it requires an IV infusion, we have to see you, talk you through that, get that set up. So please let us know right away. Again, my patients who are admitted, they suffered at home. They waited till it got really bad, and then they let me know later than I could use some of those tools. Other things that are definitely good. Something as simple as nasal saline flushes. They seem to be helpful if given early on. They're not a miracle. None of these things are miracle cures in their own, but they all add up some. Again, making sure you're getting good rest, adequate, baseline levels of vitamin D, I think are important. Treatment after the fact with vitamin D is not panning out as well as we'd hoped, but I think it's a part of keeping yourself healthy in general. So, especially during wintertime, we're not getting out. Some supplementation may not be a bad idea. There's other things out there. Ivermectin's gotten a lot of press. And I don't know that the jury is entirely in on that. And I'll explain a little bit more on that in a moment. But one of the things that's important to know about early treatment is we really have to make sure that drug, as it's being used there, is really safe. ivermectin is safe as we typically use it, 1 dose or 2 dose regimen. If you have parasites, it's been used that way for a long time. Used in high doses every day for treatment, it hasn't been well used and studied that way. It can cause liver function study issues, hypersensitivity issues. It has a very long half-life. It sticks around a long time. So that's a little less clear. I don't know if there's a huge signal of harm, but it's a little less clear. And if you're early on in the course of disease, we have to be especially careful not to hurt you, because most of the people will do well. If you take 100 people on average with COVID, about 85 of them will do well. About 10 to 15 will get pretty sick. Several of them, or most of them, end up in the hospital, and about 1 of them won't make it. So if you take the 100 people in the beginning and we don't know what course you're on in the very beginning, there's 85 of those people that we have mostly a chance to harm, because they're going to do well no matter what we do. And 15 people that we can help some, and 1 that we can help a lot if we get things right. But there's most of the people are going to do well no matter what we do. This also leads to a lot of what we call confirmation bias, and doctors aren't immune. All right, if you come in and we do something for you and you get better, we like to feel we did it. I mean, it's kind of human nature, right? You know, that antibiotic I gave you for your virus and you got better. Antibiotics don't treat viruses, but some people do it just in case or something along those lines. If you got better, everybody feels like, oh, it must have been the treatment that we did. But most of the people with COVID are going to get better. Similarly, when people say, oh, my friend took ivermectin and they got better, well, that's what most people do. That's the expected course. It really takes large studies to figure that out. Now, people will say that there has been a lot of studies, and there has been a fair amount done with ivermectin. The one big issue that we're seeing so far, well, 2. 1 is quality of studies, but 2, a lot of these studies were done in third world or places that parasites are very prominent. Iran, there's been several studies out of, and Egypt as well. In those places, the rate of low-grade silent parasitic disease is about 50%. So if you take a person who has a parasite, Strongyloides or whichever one is there, and you give them COVID and then give them steroids to treat the COVID, which steroids and parasites tend to make them go wild, so to speak. It unmasks your immune protection that you're keeping them at a dull roar. Well, the people get much more sick. And yes, ivermectin helps those people, and probably a lot of people in those countries, because it cures the parasite that was sitting underneath the surface, just coexisting, causing minor issues. But when they got really sick and got put on steroids, it got much worse. Ivermectin makes them better. So it really takes studies that are well done and take some time in first world countries to make this more clear. And so far, the couple of studies that have come out in the U.S. are not very positive at all. Now, that doesn't mean it's impossible if there's another time or a different situation that there could be some benefit, but it makes it pretty clear this is no miracle for sure. And it makes it much less likely. And again, if the only window that it seems to have a possibility of being helpful is real early on, that's the same time that we have to be the most careful that we don't accidentally hurt you. So that's those are all important things to recommend or to think about with this. Definitely talk to your doctor. There are some new things there are new things that are coming. But before I get to that, let me talk about making sure that you contact your doctor about those monoclonal antibodies, and emphasize that one more time, because that early is critical, and you got to talk to your doc about that. But we'll all try and expedite that to make sure so that happens. The other exciting new thing is there's a new antiviral called molnupiravir. It was originally being developed for influenza. It seems to have pretty good effectiveness against COVID, so its review is getting expedited. It reduces hospital admissions by about 50%. from what we've seen so far. That's really impressive. And that was a pretty well done study. If that can be verified and we can get this out in production, because again, it's a fairly new drug, it could be exciting. It works by basically causing the replication of the virus to become catastrophically damaged. As it's trying to replicate and go through its genetic material, it inserts errors, and it makes enough errors that it's just catastrophic and doesn't work at all. So molnupiravir is exciting. It's not available yet. Hopefully it does get expedited, and hopefully it pans out, because it's very promising. It's one of the few things that's really come through a solid trial and looked good. And there's one other medication that's gotten through a trial of repurposed drugs. There's something called the Active 6 trial that they're looking at a bunch of repurposed drugs, ivermectin among them. And this is called fluvoxamine. This was originally developed as an antidepressant. It's exciting too. That has a lot of drug interactions, so we have to be careful with that were we to decide to use that. But it did pass through the pilot study. One of the two arms of ivermectin did not pass through that. It failed that pilot study. There is still one other arm of a 1-day course instead of a 3-day course that they're going to that they're still following through on. But anyway, that's where that's at. I understand we have some questions. We're going to move to questions. We're about 15 minutes in here. So, Matt, if you can go with that, I'll get a drink here while we're doing the question. Okay. Can we get our booster at CGH? And thank you for reminding me to talk a little bit about boosters. If we have Moderna here, so if you need, in the future, if you need a Moderna booster, we can probably do that. Right now, we do not have Johnson & Johnson and Pfizer. Pfizer is the one that's indicated for a booster. So the next question that goes with that is, do you need a booster? And a big part of that is, what's your goal? If your goal is to just avoid the worst of this, I don't want to end up in the hospital. I just don't want the really bad outcomes, but if I get mildly sick or I need to be quarantined, that's not a big deal to me. And you're otherwise, have an intact immune system. That's an important thing. Then the 2 shots of most of these, and including Pfizer, work pretty well for that. If I want to have a high enough active antibody titer that I'm not just relying on memory cells, but on circulating antibodies to really stop this right at the door, because I'm either in a high-risk situation, I'm a higher risk person, or my preference is I don't want to deal with any of this, then boosters become more important. But it does look like vaccination and previous immunity do a pretty good job of getting the memory B and T cells there in a person with an intact immune system. So I keep mentioning that. What does that mean? If you have an immune compromising illness, or you're over 65, that starts to become kind of an immune compromising situation too, especially as you get into your 70s. Your immune system just doesn't work as well, and you kind of act like a younger immune compromised person. In those situations, 2 doses may not be enough in general, and especially for people who have organ transplant level immune compromise, they're on immunosuppressants, stuff like that. 2 doses is not enough really from the beginning to get good memory cell activation. You really need 3 doses. So you really need a 3-dose regimen, like polio. Polio, you give 2 doses early and 1 dose at 6 months, just to get that really solid activation of your immune system. So for memory cell function and just decent protection, if you're a high risk person, if you're older, you need 3 shots. If you're lower risk, but you really just want that, you're just in a high risk situation, or you really want the best protection from any level of COVID, then you probably need that booster. So that's different in a way than a 3-dose series. And if you really want that super high level of protection, it may need to be, you need boosters, periodically. We'll have to see how this pans out, but that seems more likely. I think it's less likely you'll need boosters to keep the level of protection that keeps you out of the hospital or not dead. So there's that. Let's move on to another question. Mixing and matching Pfizer and Moderna, can this lead to increased antibodies of a broader nature? Will antibodies boost at a similar rate, getting to the booster of the original vaccine, more antibodies, fewer antibodies, broader spectrum antibodies? So I can now talk about this a little bit. As of yesterday, the mix and match study, through mixing and matching Johnson & Johnson, Pfizer, Moderna, they took a little over 500 people, and I forgot how many months out it was from their original 2 doses. They did the mix and match thing, and they looked at antibody levels and how that went. Super interesting. This came out just yesterday because the FDA advisory committee, the independent committee that advises the FDA, is going to be looking at this data today and tomorrow. So it came out, and there's a lot of data coming out with that. And as far as mixing and matching, now this is, I need to be clear here. This is not official guidelines and recommendations. We're not there yet because they're about to talk about that over the next couple of days, and then official recommendations will follow. But as far as the data itself, mixing and matching does seem to be at least equally effective in terms of the mRNA vaccines. Moderna seems to give you the best response at any level. Now, the one caveat with that is this is the original dose of Moderna, the original 100 microgram dose. The booster that Moderna is proposing is 50 micrograms, and that's not what was in this study. It's likely fairly similar, but it's not quite the same. Where there really seemed to be an advantage to mixing and matching was after the Johnson & Johnson vaccine. You got about a 4-fold increase in antibody titers when you gave another Johnson & Johnson vaccine. If you gave a Pfizer, it was about 37 times increase, and Moderna was like a 70 times increase in antibodies. So this will be really interesting to see how this plays out over the next few days about what recommendations are, because this could definitely make it interesting in terms of what booster you might want to get if you have a Johnson & Johnson. The Johnson & Johnson will certainly help, but there's a reason why it may not help as much. The Johnson & Johnson is a virus vector. So they take an 85, like a cold type virus, and they put a DNA that makes you make COVID spike proteins in that. When you use a DNA vector, your body sees. When you use a viral vector, your body sees that that virus as something foreign and makes antibodies to that. So the second time you give it, your antibody is like, "Oh, we've seen this before. I'm going to destroy some of that." So it destroys some of the vaccine on its way in, and that becomes a problem for the second dose. The mRNA vaccines don't have that problem. The little lipid fatty bubble that they're in doesn't stimulate that immune response. So the second dose doesn't get destroyed on the way in, or the third dose, or whatever that is. It's not a problem for that type of a vaccine. So that mixing and matching, stay tuned. That's really interesting, and we'll have to see. But the general theme was Moderna works best. Pfizer is pretty close second. And Johnson & Johnson doesn't seem to add much when given to one of the mRNA vaccines. There's a thought that might be because if you got an mRNA vaccine before, you don't have the antibodies to the viral vector because you didn't have the Johnson & Johnson the first time. And would that help? It doesn't look like it from that data. The only thing we don't know yet is the one unique thing about Johnson & Johnson, as though it doesn't have a rapid rise in antibodies, it does seem to keep rising for longer than the mRNA vaccines. And this data only went out about 30 days. So it's possible that over the long term, the Johnson & Johnson could look better than it does right now, but it has a lot of catching up to do. So, okay, next question. Moderna booster. Yeah, the booster, as of today, it's only recommended for people with Pfizer, or if you have a high level immune compromising illness, then it's Moderna or Pfizer. But for the general public, the regular person, even the person over 65, as of today, it's only Pfizer. Moderna is definitely holding up a little bit better. We think that's for two reasons. One, it's a little higher dose, which is why it has a little higher in the way of day after side effects. And two, there's a little bit more time between the doses, which seems to be helpful in terms of effectiveness. But it's holding up better. Is it enough better that they're going to say hold off on the booster for now? I don't know. That question will be answered maybe over the next 2 days. They'll be talking about it over the next 2 days, but certainly over the next couple of weeks. There's a bunch of meetings scheduled in the various regulating bodies. The first one, again, is the Independent Advisory Committee. I like that one a lot because it's independent, very bright scientists, people like Paul Offit, really, really bright guys that don't have any specific connection to industry or government. In this case, they're the independent body that reviews this. And interestingly, this independent body, when sorry, that's my pager going off. When they were asked about the original plan to give everybody over 16 a booster of any vaccine as of September, 16 out of 18 of them voted no, that there wasn't data to support that broad of use of boosters at that point. So that is encouraging and reassuring that they don't go where the data doesn't point them to. They're not just a rubber stamp yes thing. Now, when the question came back later about what about higher risk people, what about people over 65, they did vote for Pfizer boosters because we had the most data from the little faster decay of Pfizer protection and the risk in older people. They did vote at that point to go ahead and do boosters in that population, but not for everybody because they didn't think that was warranted, and to this point still don't. Okay, next question. How long should one wait on the flu shot? I've read the efficacy is only about 3 months. Is that true? Okay, very good question. And the efficacy of the flu shot does drop off. I just saw an update on that as well. And the amount that it drops off per month is in the low single digits. I'm forgetting if it was 3 or 5% per month. But it doesn't drop off like a cliff. It's not 3 months and then it doesn't work at all. It's most effective after, the first month, and after that it drops off, a single digit percentage each month after that. Now, I'm not a big fan personally of getting it way back in July because you keep adding up 3 or 5%, for the 6 to 7, 8 months until you get to February, March, where often influenza is the worst, and that does start to add up. But if you're getting it anytime around now or later, I think it's very reasonable. The amount that it would decline by February or March is fairly small, and you really don't want to be caught out a day too late because then you have no protection, not just less protection. And again, it's not an all or nothing thing. If you do get influenza and you have the vaccine on board, you're less likely to get really sick with that. So any time from now, October on out, I think is reasonable. Next question. How long after the flu shot can you get your COVID booster? So it had been that we were trying to keep this all separated for 2 weeks just to make sure that we could separate out what was a COVID vaccine issue versus a flu vaccine issue. And, in terms of that, separating it by 2 weeks is probably still a reasonable or good idea. But the guidelines did change to say you don't have to wait. If if there's only one time that's really convenient for you, they don't interact with each other that we can see. You can get them at the same time or within 2 weeks. But in terms of just sorting out, if you do have some sort of reaction, what's doing what, separating it by 2 weeks seems reasonable, but you don't have to separate it. There's no interaction. It's not going to make one work better or not work better, that sort of stuff. Okay, next question. Long COVID and the fully vaccinated. I read that 30% of people who have COVID will have some form of long COVID. Are you seeing similar numbers of COVID survivors with long COVID? Does vaccination help prevent? So I've only seen a limited amount of data on that. And I don't know that it's enough because it wasn't a head-to-head comparison at the same time. The rates are less, but it can still happen, vaccinated or not, but it seems to be significantly less. I don't know that I can give you a specific head-to-head comparison number, but remember, one of the things to think about is we're looking at the breakthrough cases only. You're less likely to have any case if you get vaccinated. So you can't get long COVID if you don't get COVID at all. And we know that vaccines, depending on which one, prevent, 60 to 80 some percent even of Delta. So if you don't get it to begin with, you don't get long COVID. And of the people who break through, it seems to be significantly less, though it does still happen. So you have some protection in terms of not getting it at all, and some protection in terms of it not likely being as bad. Let me talk a little bit about the contagion stuff, because that goes with that, and that's been a big topic. It came out a while back from the Provincetown outbreak that people who are vaccinated can have up to the same viral load as someone who's vaccinated. I even saw something that said people who are vaccinated had 251 times the viral load of people who are not vaccinated. That study, they weren't actually comparing vaccinated, unvaccinated people now. They were comparing people who got the infection when it was the alpha strain and all that to people who had a breakthrough infection with Delta. Those are two very different things. Delta makes for much higher viral loads, like 1,000 times. So it's not surprising when you're comparing those groups, if you get to the point of having a breakthrough, that yes, you'll have higher viral load than people who got the alpha strain way back when. But that's not a comparison head-to-head of people who got vaccinated, unvaccinated with Delta. So that's how this misinformation stuff can happen sometimes. But in any case, let's say you do have a breakthrough case. Your viral load, because Delta replicates very quickly up in the nose, your viral load goes up very quickly, all right? If you're vaccinated, though, two things happen. One, your viral load starts to drop very quickly because your body sees it, recognizes it, and gets on it very quickly with your immune system. And two, that viral, the virus that we're finding may not be alive or viable. So when they try and take vaccinated people, even with the same viral load, and swab their nose and put it in a petri dish and see if the virus grows, if they can make it replicate, most of the time it doesn't grow well because the virus is being damaged, it's sick. Remember, the test that they're looking at to determine viral load measures the RNA, the genetic material. That, just as dead people still have DNA, dead viruses still have RNA in them, and we can still detect that. Just like the people who are, some people can still have test positive a month out from when they're sick. They don't have active, viable COVID virus. They have viral fragments and pieces of RNA that we're picking up. So the same thing happens with this viral load. The third thing that's important with that is you're much less likely to get infected to begin with, like we talked about before. If you're vaccinated, so you're not as likely to be in that position to begin with. And then if you are, your viral load is only briefly as high and not likely as much viable virus. And then it also goes down much more quickly. So instead of having this long tail of contagion, your contagiousness is much shorter and falls off more quickly. So that's another nuance that's important when people, and to an extent, the CDC, I think, didn't do a really good job of explaining that what we didn't know at that time. All we knew with the Provincetown stuff is two things. One, people could have a very high viral load in their nose, and two, people could transmit it. We didn't know how often that happened at that point. So obviously, because that was a change from before, from Alpha, there was some understandable concern with that. But I think it would have been appropriate to say what we don't know is, does this mean that people transmit it as much, as likely? Does a viral load stick with you? Is the virus viable? Those were all the things we didn't know. All we heard was the viral load can be the same, which is true. It can be, but all those other caveats still apply. So, okay, next one. Your opinion, 11-year-old going to be 12, December 28th. Vaccine for 5 to 11 comes out in November, maybe. Wait until he turns 12 or get the vaccine ASAP when his age is available. All right, well, a couple of things. One, that's going to be talked about in the same independent panel coming up over the next couple of days, and again through the end of October. So all the data on that is going to come out in detail. So in the next thing to know is they did decrease the dose for that age group. So instead of the Pfizer's 30 microgram dose, they're going to get 10, and kids younger than that will get 3. So it's a third and a tenth of the dose as you get smaller in age. It's not a weight-based thing. It's an age-based thing because of how your immune system reacts to that. The FDA did extend out the time that they demanded for safety data because we wanted a really good look at the myocarditis rates at those lower doses. Because again, if we're giving this to people who are lower risk, and kids are certainly lower risk, we have to be that much more careful to make sure that safety, all right, that we're making sure that safety signal is not showing up. So to answer your question, your kid will be 11. They'll be at the top end of that. They'll be getting the lower dose. My sense is that the greater risk is in waiting. Obviously, there's always that balance. I think the greater risk is in waiting. But before I can say that definitively, I'd really like to see what the independent panel does with all the data that they'll be looking at soon, because there's a lot of stuff. I've seen some of it. I haven't seen all of it. My gut feeling is that an 11-year-old, and we're giving them the lower dose, I think they'll probably be fine. And I think the greater risk is in waiting. Interestingly, kids in the beginning, they made up 3% of cases. Kids are now making up 27% of cases. Some of that is because we're testing more in schools. But a lot of that is they're the susceptible population have been vaccinated or have gotten sick and have some level of immunity. Kids were sheltered a lot more. They were out of school. Now they're more of the susceptible population. And while kids get sick less often, we were seeing 2,000 kids a week get hospitalized in this recent Delta wave. So they still get sick a lot. They're tough and they don't end up dead very often, but they get sick a fair amount. And keep in mind the myocarditis rates, when we're worried about that, are significant after having COVID. When they studied the Big Ten players, it was between 2 and 3%. They did MRIs on everybody, all the Big Ten players who had COVID, and they could see visible evidence of heart inflammation, which is what myocarditis is, in about 2 to 3%. Now, keep in mind, this is inflammation, not necessarily long-term damage. Most people, whether it's viral induced or especially the lower level we're seeing of this inflammation from vaccination, they get better treatment or even no treatment. But still, we want to be aware of that, and we want to take the lower risk, whatever that turns out to be. So we'll see what the final data shows. All right. Well, next question. A 12-year-old daughter had an infusion. When can she get the shot? So I assume you mean the monoclonal antibody infusion. For that, we have to wait 3 months because the antibodies that stick around from the monoclonal antibody infusion through about 3 months can interfere with how well the vaccine works. That's definitely a problem. So you have to wait 90 days. That said, because she's had COVID and she's had the monoclonal antibodies, she's at really low risk over those 90 days. I wouldn't be too concerned about waiting. That's I don't think that would be too much of a worry to wait on that. Now, keep in mind, monoclonal antibodies don't necessarily protect you. If you're in the specific situation where you didn't have COVID, all right, you went out, you're a high-risk person, you had an exposure, which I should mention is a new indication for monoclonal antibodies. You're a high-risk person, you were closely exposed to somebody who had COVID, you're really worried about what this could do to you, especially if you're not vaccinated. You can now get monoclonal antibodies before you're sick. That's a new indication. We've had it out long enough that we're comfortable giving it that early on. In that case, if you have another or an ongoing exposure and you're at risk again, you'd have to get another monoclonal antibody infusion after 30 days. That's separate than if you got sick and you got you're having COVID and you got the monoclonal antibodies, then you have to wait 90 days before immunization. All right, well, next question. Hope everyone is watching this and educating themselves. Thank you. Yes, that's what we're here for. It's to give good information. All right. Mary has our regular. I saw her just recently, and she's always on every week. She almost always has questions, but none this week. So I'll take the thanks. We appreciate that people are interested in getting educated. We have any other questions, Matt? Nope. Okay. One last parting thought. I was listening to okay. We do have one more. COPD. Can you advise how important it is to get vaccinated? So, interestingly, the very biggest risk factors seem to be the metabolic ones, the diabetes, the heart disease, even high blood pressure is a significant risk. And those things people don't always appreciate. They think it's only the people who have lung issues, but the inflammation of COVID affects every organ. So those are actually the biggest risk factors. That said, if your lungs are already compromised, which is what COPD means, and COVID gets bad, now I don't know that COPD makes you have a worse case of COVID. But if you're going to have a bad case of COVID and your lungs are already compromised, then you're in more trouble. Your outcomes are going to be worse because of that. Sorry, it's my pager again. Make sure this is nothing urgent here. Unfortunately, I'm still on call for my own patients. So okay. So as far as COPD, getting back to where we were that way, if you're unlucky enough to have a bad case of COVID, it's going to be worse. You're more likely to end up with more assisted breathing. You have less reserve to work with. So yes, it is more important to be vaccinated. COPD people are not at higher risk from getting vaccinated. We know that's the case. I should also bring in pregnancy because that's a big thing as far as risk factors. In the beginning, one more question. Let me finish up on pregnancy. There's been 3 stages with pregnancy. In the beginning, normally we say, because we didn't study it, vaccines are contraindicated in pregnant people until we get there and study it. Because we knew that bad outcomes for the mom in particular are about 2.5 to 3 times the rate in pregnant people. The first recommendation was, because we know there's significant risk of COVID itself and not being protected, and the way there were certain people who, even they weren't supposed to get pregnant during the trials, about 36 people did. Nature finds a way, as they say. And the data looked good in those people. The first round was, you might make a reasonable choice to get it, even though we haven't had long-term studies, because we know there's a significant risk of doing nothing, and what little data we have looks okay. That was the first. The second phase was, oh boy, We now have some data from the V-Safe and pregnancy registries that things look pretty good, and we're really seeing a bigger rise in pregnant people having bad outcomes. We recommend you should probably do that. That was the second phase. In the Society of Maternal Fetal Medicine, American College of Obstetrics and Gynecology, they all moved up their recommendations on that. Now there's kind of a third step to say, we now actually have formal studies to say people really did do well. All right, we've looked at them in well-designed formal studies, and the outcomes have been very good. No bad outcomes in terms of pregnancy. And we are, again, especially in places like Mexico, we've seen a rash of really bad outcomes. In our own hospital, we've seen really tragic cases in people who are pregnant and unvaccinated. So now there's an active campaign to say, if you're pregnant, you really should get vaccinated. The risk is very clearly greater. So that's kind of the third level of recommendations that we're at right now. There was a question on asthma versus COPD. Similar that way. Asthma doesn't necessarily make the infection worse or the disease process itself worse. You have less reserve and a little bit more, you're more likely to get in more trouble because of that. So it is a good idea to get vaccinated if you have asthma. In particular, it's also one of the risk factors that we consider for monoclonal antibodies. But keep in mind the criteria for monoclonal antibodies is now all the way down to a body mass index of 25. All right. My body mass index is significantly over 25. Probably work on that a little bit. So I would qualify as a not low risk person for monoclonal antibodies at this point, were I to get COVID and have some symptoms that I wanted to get a handle on early. So it doesn't take much to qualify, but asthma is one of those risk factors that even early on, even when the bar was higher, because we didn't have as much data to know that it's safe, we reserved it for higher risk people. It used to be a body mass index of 35, which I definitely am not at a body mass index of 35. But that used to be the level, but that's changed now. That's down to 25. But asthma is a risk factor and so you should both get vaccinated. And if you get sick, get monoclonal antibodies. All right. Les Wilson says, I have COVID over a year ago and I had both the Moderna shots over 6 months ago. I still don't have my taste and smell. Will the booster help? So the loss of taste and smell is interesting because this is some level of damage to the olfactory lobe and the nerves going to that. This is normally when you get sick, you can't smell or taste because your nose is clogged. All right. COVID gets deeper. It goes up into the nerves that go between your sinus cavity and the brain. And when they do MRIs of people who before and after COVID, one of the things that they see is your olfactory lobe has been damaged. It's smaller, and the nerves going to that have been damaged. So learning how to smell again is more like learning how to walk again after you've had a stroke. You've had damage to that part of the brain, which is a little bit of a scary concept that way when people talk about, oh, COVID is no big deal. Even in, a lot of people have loss of smell and taste. And if it's really minimal or minor, maybe it is just the congestion. But if it's persisting, that indicates that you've had some degree of brain damage from that and the nerves that are going to the brain. So will a COVID booster help that? Unfortunately, probably not. The best way to try and work at that is to try and they even have some commercial kits now out where you try and retrain your sense of smell. You take something that was really strong in your brain from childhood, the smell of apple pie or whatever it is, be racing fuel for me, I think, because that's my thing. Something that if you picture it, you can smell it. Although I probably shouldn't use this if that were ever coming up to me, because inhaling racing fuel is not a good thing. But for people who have more normal memories of childhood stuff like apple pie, get a scratch and sniff sniffer sticker that's apple pie. Scratch that. Imagine that apple pie. Train your olfactory lobe to walk again, so to speak. When people have paralysis, they have to look at their toe and imagine their toe moving until it finally starts to twitch and wiggle, and then they work on that. It's kind of a similar thing in learning how to smell again. Is myocarditis permanent after a severe case of COVID? Typically, no. Almost universally, no. So let's break down what myocarditis is. Myo is muscle, card is heart, and itis is inflammation, if we break down the Latin. We've all felt myositis, which is an inflammation of the muscles. When we get sick and we have that everything hurts, that, oh, I feel like I've been run over by a truck, it hurts to move my eyes, it hurts to move my muscles, all that sort of stuff. That's myositis. That's the muscle being inflamed from the virus. When the inflammation goes down, the muscle gets better, and there's usually not any significant long-term damage from that. When you have COVID or some other viruses that can do that too, and the heart muscle gets inflamed, you have pain in the heart muscle because of that inflammation. It's the same or very similar process to what's going on in other muscles when we get inflamed, but this time it's involving the heart, or sometimes the sac around the heart, the pericardium. And so that inflammation causes pain. The vast majority of time, that inflammation goes away, nothing bad happens, and it's back to normal, and the myocarditis doesn't tend to be a big issue. There are rare cases where the inflammation gets so bad that there's damage to the heart muscle that's long-lasting. That's very rare, even among cases that happen with myocarditis. Sometimes we see this in the MISC, the multi-inflammatory system COVID, that rare late inflammatory issue that happens in kids most often. Usually, I think the median age is around 9. Sometimes when inflammation gets that bad, the inflammation's so bad that there's some level of scarring or damage to the heart. But that is thankfully pretty rare. It's a little less rare after a bad case of COVID, because again, COVID is super inflammatory and all your organs sit in this inflammatory soup. When we look at sedimentation rates, things like that, markers of inflammation, normal is, in the single digits. If you have rheumatoid arthritis or some other inflammatory condition, often it goes up into the, 40, 50 range if you're really feeling miserable. I've seen not uncommonly inflammatory markers in the 150 range, sometimes maxing out the test with COVID. It's an enormously inflammatory thing. So the myocarditis that comes with that tends to be a little longer lived and a little more serious and a little bit more risk of heart damage. I have personally experienced one person who had catastrophic heart damage. They got through COVID, but their heart was catastrophically damaged from that. I have not seen any of that I haven't seen a clinically apparent case of myocarditis from vaccines. I wouldn't doubt that there was a mild case that someone just kind of didn't address or kind of blew off. But as far as something that they came to me to talk about, I have not seen that yet. Speaking of side effects, let me give a quick thing. I know we're running long here, but this is also something that's in the news about VAERS, right? Vaccine Adverse Event Reporting System. It's important to know what this is and what it's intended to do. It's an important system as a catch-all for anything that could possibly be related to vaccination. We want to know it all, whether it's likely or not, it doesn't matter. They actually changed the guidelines for physicians. The instructions for us now is if someone dies anytime around the time they have vaccination, we should report that. We're required to report that to VAERS, whether or not we think it's related. All right. If someone died, it's not up to us to figure out whether it's related. It's up to the people who analyze the VAERS data to go in to look at that. So they'll go in, they'll pull the medical data, and they'll look at whether this seems plausible that it's related or not. So that's one thing. That's one of the reasons that the reports of errors have gone up, because before we used our judgment a little bit more about whether we thought it was related. Now we're instructed to leave that to the true experts and we just report it. The second thing is, and before I get to the second thing, actually, so keep in mind that the vaccines don't prevent all the other things that can happen to us, right? Many people die every day from all sorts of things. And statistically, there's going to be some overlap with people who are getting COVID vaccinations. And because of how we're instructed to deal with this, those are going to show up in VAERS, all right? So if someone has something that's clearly unrelated, that's still going to show up in VAERS because that's what our instructions are to do. Now, behind the scenes, the people will go and look at that and say, is this likely related? Is it also higher than the background rate? We know how many people die every day from this sort of stuff in general. Is this a higher rate in vaccinated people, or is it a lower rate? That's how VAERS data can be useful. That's how we found out about the Johnson & Johnson blood clots, not because they were common, but because the background rate of those particular type of blood clots, immune-mediated complexes, that the background rate of that is almost zero, very, very small. So when we saw this pop up, we're like, oh, this doesn't normally happen at this rate. This is something we've got to investigate. And it is true in very rare cases. You know, it's in the per many hundred thousands to per million, depending on what group you're in. But in very rare cases, that is related to vaccinations. And that's how we found that. But for other more common things, unfortunately, like people die every day, and sometimes that overlaps. So now to get on to the second thing, VAERS is open to anybody, and I mean anybody. If Aunt Matilda feels that their great niece had a bad reaction to COVID, they can log into VAERS and submit a report. That report looks just the same as if I reported that. Obviously, the experts behind the scenes who look at the VAERS data will then go in and determine, is this something that seems reasonable? But VAERS is meant to be a very catch anything that's possible, all right? It doesn't mean that everything follows that was caused by that. It's a method how we can figure out, oh, this rate looks worse than normal. We need to look into this deeper. But it's not something you can make conclusions on in and of itself. All right, we'll reply to any additional questions we didn't get to. Thanks for all the questions. We are about an hour in, so I think that's going to have to do it. Thank you for a long session, and hopefully this is helpful. Signing off.